thank you to all the organizers for organizing the event and for sharing the podium with me so that I can give you my thoughts on triple negative breast cancer and talk about what's new in triple negative breast cancer. And, hard to talk about what's new without talking about what's old. So we'll talk a little bit about where we came from and how we've gotten here and what does the future hold for us. Um, so, the overview of today's talk, you know, not that much different from when I teach, the medical students, but obviously we'll uh, uh, make sure we do it in such a way that we can understand all the terms and whatnot. But for example, epidemiology, of course, we're talking about why me? Why did I get triple negative breast cancer? Who gets triple negative breast cancer? The biology. Sorry, we'll talk a little bit of biology. So you have to, take a little bit of your biology sort of 101 and a little bit some math skills to be able to understand, moving forward just a little bit, just a little bit. Um, and then, of course, at the end of the day, a lot of us ask the question when we're sitting with our oncologist, what does my future hold? What am I in danger of? What can I do about it? What are all my options? And of course, should I consider a clinical trial? Because that's the only way we can move forward. And, for short, I'll be referring to triple negative breast cancer as TNBC. Um, First and foremost, I like to start my talk by making a point that breast cancer is not a new disease. So this is a painting from way the 1600s where Sir Peter Paul Rubens, he basically painted what he saw, more of a realistic style. And here we can see that the woman on the right actually has what appears to be advanced breast cancer. So, it's not a new disease. Is Yes, of course, we'll be talking about, could it be some environmental factors contributing? But, sometimes we have the impression that, oh, it's so much more common. It's happening, more now than it's ever been. What are the factors and that we can control? And, I'll be the first to admit we don't know it all. But we can share what we do know. And first and foremost, really you have to understand what is normal to then understand how normal can lead to abnormal. And well, what's normal is that the human body is a very complicated being. As you know, we start off as teeny tiny cells when we're conceived, and we turn into this, human being composed of millions and billions and trillions of cells. Um, and I actually consider the breast one of the more complicated organs because when baby girls are born, they're born without breast. It's not until, when you reach puberty that whole bunch of signals and sure hormones, but a bunch of signals turn on and off, and now all of a sudden the breasts form, they grow, they don't grow forever, they stop growing, and then through, the the lifespan and reproductive years, the breast is growing and shrinking, and the cells are eager to, to change, to turn into, to make milk, and to get ready to get pregnant and all that. So um, the reality is that we are all born with cancer-preventing genes and cancer-causing genes. That's not what they're meant to do, but they control the growth of these cells, right? These cells, they are supposed to grow and divide at some point, and they are supposed to die at some point. And these switches break constantly in all of us, or these genes mutate constantly. It's how human beings evolve over time. Now the catch is there is mechanisms within our body that fix these mutations. And for the most part, breast cancer, triple negative breast cancer forms because these mutations weren't fixed. And now you have a switch that's on telling the cells to grow, and they grow forever. On the other hand, a switch that is supposed to tell the cells to die doesn't turn on, so you have an immortal cell growing out of control. That's what cancer is in general. And we'll talk about how, what these switches might be. Of course, what's dangerous is when, and here the representation of ductal carcinoma, very rarely lobular carcinomas can be triple negative, but for the most part, they start in the duct. And so when these cells start to acquire, can you see this here? No, I guess not. Okay. This guy. Okay, see that? Okay, there you go. So these are the cells that are meant to grow and die towards the middle. As they acquire broken switches or mutations, they fill up the whole duct, non-invasive cancer, non-life-threatening cancer, and then when they break outside the wall of the duct, we call that invasive. That's what can be dangerous. That's what has the potential to spread. When it comes to the causes of triple negative breast cancer, well, the majority is sporadic. Even in young patients, the majority is sporadic. It's a lottery that we obviously didn't want to win, but a lottery that our number can be picked anytime. And so 70% of the time, it's sporadic. Only about 5 to 10% of the time do we actually find the actual root of the cause, which is what we call hereditary breast cancer. Which is we were born with a genetic predisposition for the cancer to happen. When we do have that type of, and actually, what's important to note here, sporadic is many times, a lot of you are, incredibly healthy and fit and, run marathons, yet this happened. And we sometimes try to look back and think, what can I change? What can I do? What did I do, that caused this? And one of the worst things that you can do is change your lifestyles, because your lifestyle might be as good as it can be. And, changing your lifestyle might be doing you a disservice. So, keep that in mind. Now, we can all do something about making our lifestyle a little better here and there, but, keep that in mind. So, BRCA1 is probably the more common gene that predisposes the most to triple negative breast cancer. So, what this means is that when a patient has a BRCA1 mutation, that you're born with it, when you do get breast cancer, more than 50% of the time it's triple negative breast cancer. Just recently, I want to say about 2 months ago, a recent, maybe a little more, recent clinical study done by Fergus Couch revealed that these other 4 genes also predispose to triple negative breast cancer. In the past, we used to treat for only BRCA1 and BRCA2. The field of genetic testing is ever evolving, and I think it's important to note that whatever gene you had done, I mean, we shouldn't refer to it, I had genetic testing and I had negative. I think we need to look at the specifics of what genes did you test for, when was it done, was the full panel done, and guess what? Next year, who knows? Not likely, but who knows? Maybe a new gene will be tested for, and what you tested negative for may be an outdated test. And that's one of the reasons why to continue to follow up with your oncologist, who would say, on top of the situation. Very important that when it comes to, risk factor is not the cause of triple negative breast cancer, or it's not the cause of cancer, but it's factors that can potentially increase or decrease the chances that you get breast cancer. So don't look at this like, oh, that's the reason the cancer happened. The average age of breast cancer is about 62, but patients with triple negative, it's more likely to be diagnosed in people younger than 50 years old. And what I'm trying to point out here is, unlike hormone receptor-positive breast cancer, where having multiple children and at a younger age, that seems to be protective against hormone receptor-positive breast cancer, that seems to play the opposite role in triple negative breast cancer. But then what is interesting is that, when we do have multiple children and breastfeed, that seems to reduce back down the risk of triple negative breast cancer back down to average risk. So, yet another sort of a positive thing about breastfeeding, that it could potentially reduce the risk of triple negative breast cancer. Now, that's not to say, we'll get pregnant and breastfeed all the time. It's just, the data that we have. Of course, we vouch for early detection. Mammograms every year significantly increases the chances of detecting breast cancer early before it has spread, but it doesn't guarantee a cure. And unfortunately, early detection for triple negative breast cancer is not as good as early detection for other kinds of breast cancer. Many times we have what's called interval breast cancer. So interval breast cancer is when even women, when they start doing their mammograms at the age of 40, you get a mammogram, it's normal, and then 3 months later, the mass might come, and even though that mammogram initially was negative. So, and then before the age of 40, it's even harder. Sadly, our detection. Well, first of all, because it's not as common, we don't have any strategies to screen for triple negative breast cancer to the average non-high risk population. But when we do have sort of genetic mutation carriers, or sometimes we've been treated for lymphoma in the past, and the high doses of radiation to a developing breast can significantly increase the chances of triple negative breast cancer. Well, in those patients, we do strongly recommend MRIs because it can improve early detection. And of course, early detection can be key. We can't be afraid of finding cancer. We got to be afraid of finding when it's too late. And again, for early detection, really, we can mainly help women over the age of 40 with mammograms, and not so much under the age of 40, unless we have had, genetic counseling or testing and tested positive for high risk. Here we want to detect it early, but because when it does get advanced, that's when our chances or effectiveness of treatment is not as good. Of course, breast cancer is not one disease. When we first were able to figure out that there's some that are hormonally driven and some are not, I think part of the clue that kind of led to physicians to think about this, which was back in the day when breast cancer occurred and we didn't know what a lot of what was going on. We saw there was a description from this famous English physician where he described a patient with locally advanced breast cancer. She was roughly in her late 40s, and then after she had gone through menopause, the tumor totally regressed. Didn't regress forever, but I mean that's what started to make us think that okay, there must be something hormonal about this particular type of cancer. And of course, about 15% of the time is triple negative. So what exactly does this mean? Well, it's about these sort of broken switches that we look for. The more common type of breast cancer, this is a test that we do to detect if there's the protein in this cancer, and if this protein, if we see it in the cancer, then it can help us figure it out better. So most common type of breast cancer is the one that feeds off of hormones, estrogen and progesterone. And however, we sometimes test for these receptors. It is breast cancer, but it's not driven by estrogen or progesterone. And then a third protein that was subsequently discovered that can also distinguish another 10 to 15% of cancer is HER2. But then ultimately, it's none of these switches or genes that are affected. That's where we get triple negative from. So it's really a diagnosis of what it isn't. And so therefore, we will learn about how within this type of cancer, there's many different types. Again, with HER2, this is the same thing. It's about those switches that I was telling you about. It just so happens that that's the one that the switch is constantly on, and it won't turn off. And there's too many of them, and that's what defines HER2 positive breast cancer. Again, the threat with any cancer is the possibility that it may sneak into the blood, travel to distant parts of the body. It could do it through a lymph node. It could bypass a lymph node, and that's what can be life-threatening. And one of the most important questions that you would sort of pose your treating physician is, okay, they did surgery, they took it out, margins were negative, am I, is this cancer still in me? Is it going to come back? And the truth is, there isn't a perfect test. No CAT scan, no PET scan, no bone scan, no MRI, no blood test that can accurately tell us if it's been completely eradicated with surgery alone. Sometimes surgery could do it by itself, or was it the chemo that took care of it, or is it lingering? So we'll talk about how there might be pieces of the puzzle that can help us figure out, well, what are the chances at least? And because we do want to try and avoid that, obviously, there have been significant advances in early stage triple negative breast cancer, but no major advances in late stage until yesterday. We'll talk about that. And then there's, generally speaking, when we're diagnosed with metastatic triple negative, the median overall survival, which basically means, half of the patients die of the disease within a year and a half. And chemotherapy can work and it can help us, but it's rarely a long-lasting effect. And so we certainly do need better treatments and predictors. So here's just an example of how poorly we've done in making a difference. On the left is the differences in black and in the past versus the further advanced. So here's the only math you really need to see. So what this is 100% of the patients start off at the left, and then as a patient pass away, we go down on it. So on the left is the differences that we've made for hormone receptor positive breast cancer with newer treatments. And then on the right is triple negative breast cancer. Haven't really made a dent until yesterday. So the current best standard treatment that we have to offer patients with triple negative breast cancer to prevent cancer from coming back in the future is a combination of AC and Taxol, and maybe Taxotere, which is the cousin of Taxol. Just to know, these Adriamycin or doxorubicin. I do think, obviously, chemotherapy gets a bad reputation because it has a lot of side effects and collateral damage, but it saves lives. This medication, it's a ruby-colored antibiotic isolated from soil-based microbe. It was discovered near the Adriatic Sea in 1950, hence the name Adriamycin or doxorubicin. And then Taxol actually came about from an NCI-funded program to screen for natural products, and lo and behold, the bark of the Pacific yew tree had this anti-cancer property. And then many generations, many clinical trials, many patients, generations before us participated in clinical trials not knowing what these things were going to do, have gotten us to this point, the standard of care option for patients with breast cancer. Now, this is an example of a particular study that one of many, and in this one, many high-risk patients, that shows us how surgery can cure patients by itself. Again, we don't have that perfect test to tell us who completely got cured with surgery and doesn't need chemo. We don't have that. We were unable to do that. But when we offer the AC part of chemotherapy, we can improve chances of cure. And then when we add Taxol after that, we can improve it even more. And but the truth is that there is a percentage of patients that are chemo resistant. And again, in this graph, it's very high-risk patients. Now, one way that we can kind of crystal ball trying to figure out who is uncomfortably higher risk and who is lower risk is giving chemo before surgery. When we give chemo before surgery, we remove the lump, and if there's no cancer at all, we tend to have a much better prognosis. Again, this is also a much higher risk population, so the numbers can be upwards 90% in terms of when we get chemo and there's no cancer at the time of surgery, versus patients who have residual disease. And this is key because nowadays, when we offer clinical trials, we can stop. Sure. Yeah, so I talked about this morning about the benefits of doing chemotherapy before, which gives us a lot of benefit, right? Number one, downstaging a lymph node so that we don't end up with more surgery in our arm and long-term problems, shrinking the tumor, making it better for the surgery, giving us the option of breast conservation if that's what we so choose to do, and time to think about what surgery do I really want. I think there's a lot of benefits to that. And nowadays, a lot of clinical trials are focusing just on the high-risk population, as opposed to just offering even more treatment options to somebody who may not really need it, because again, even clinical trials may have collateral damage. One big question is this chemotherapy that we call carboplatin, is it beneficial? You may have not have heard about this medication. This question came about only because a recent study was done and it showed that, hey, when we add even more chemotherapy on top of what we already give, we have a slightly higher chance that we can get rid of the cancer at the time of surgery, but that didn't necessarily translate to a better chance of cure, if that makes sense. So there's two endpoints that we sometimes look at when we give treatment before surgery. Did it get rid of all the cancer? But then the long term is, did it make a difference in cancer coming back? And so even though this study showed, yeah, maybe 13% improvement, did that translate to preventing recurrence? And it was too small of a study. It didn't show that, maybe because it was too small of a study, or maybe because it doesn't do that, which is the bigger reason of why we want to consider more treatment. Is it going to improve my chances? So currently, studies are ongoing. Another question is, you hear about this medication called Xeloda. Is Xeloda beneficial? So Xeloda is, let's say you've had all your treatment and you've done everything that is currently considered standard of care. If I take Xeloda after my surgery and treatment, is it going to further improve my chances? Well, we have a couple of conflicting results. There was a Japanese study that looked at all breast cancer patients, but they specifically looked at triple negative. There were 286 of them. And actually, in that study, mainly those patients who still had residual disease within the breast, right, we talked about, who are considered high risk, and those patients who took this medication afterwards, apparently it showed that they had a better chance of cure versus those who didn't take the medication. So the conclusion is that it might reduce the risk of recurrence. But interestingly enough, a larger and more recent study doing the similar concept, basically adding Xeloda to patients with triple negative, it was a much larger study, basically showed no difference. So I think we have to interpret these results with caution. It is not, ooh, that's not good. I saw the battery. So basically showed no difference. So, and the reason to take that was, so basically it's if you end up in that situation, it's sitting down with your doctor, looking at the pros and cons, the side effects, the potential benefits, and making a decision that you feel comfortable with. I don't think there's a right or wrong answer to either, choose that or not. Because, we've done studies before, and on the left is a small study, patient with sort of metastatic triple negative breast cancer, and it was a small study, and you see a big difference between what happened when the blue, combination new treatment versus the standard treatment. And that was a small study, and we all got excited about, ooh, this is a great new drug. And then we did a much larger study, the exact same study, much larger, and it showed no difference. So sometimes we get to see results and differences by chance, especially in smaller studies. So relapses, when they happen in triple negative, they do tend to happen early. One thing is, for a patient with triple negative, unlike the hormone receptor kind, when we do have, when we get to that 3, 4, 5 year mark, the chances of a recurrence are significantly lower, and lower, as opposed to patients with hormone receptor positive. Unfortunately, the risk of recurrence continues upwards 10, 15, 20 years later. Symptoms, of course, of metastatic breast cancer, can be many, and very non-specific. And this is, what I tell my patients is, hey, you don't have to wait for an appointment. If you have any complicated symptom, you bring it to my attention. We'll sit down. We'll figure out if it's a runny nose and a cough. They don't feel too enthusiastic about doing $1 million workup and test. But if you're feeling something weird, nobody knows your body better than you. If you feel something that's not quite right, then that would warrant further testing. Sometimes, cancer comes back with no symptoms, and the reality is that unfortunately, monitoring with scans or labs and at whatever interval, unfortunately, finding the disease before the symptoms arise, that hasn't been shown to help improve our chances of survival, and that has been in countless number of studies, up to 20 studies throughout the world, where patients are intensely monitored with scans and blood markers versus just come to clinic, live life, address any concerns you have. So that's key to know. Um, yes. Okay. Hey, I might need well, I hope I don't run a battery. No, I'm good. I'm good. We'll be fine. All right. Ready? For sure. Yeah, for sure. As far as I'm concerned, yeah, you can have them all. Goals of treatment for metastatic breast cancer disease can be cured, unfortunately, but it can be slowed down frequently for many years. Um, Treatment for metastatic breast cancer is lifelong. It focuses on control of the disease for the purpose of improving quality of life, maintaining that quality of life, prolonging life, and prolonging quality of life. And the treatment of symptom, it's always palliative from day one. So, in comparison to the other, the types of cancers, breast cancers, we're kind of starting behind the eight ball. Patients with hormone receptor positive breast cancer, they've had, success in terms of managing and controlling this disease with hormonal blockers, and that can buy them a lot of time before they ever even have to see chemotherapy. Because at the end of the day, when patients with hormone receptor positive breast cancer, in which hormonal manipulation hasn't worked anymore, they're practically treated like patients with triple negative breast cancer, which is chemotherapy. So, they kind of buy themselves a lot of time with hormonal blockade before we get to chemo. And then when it comes to HER2 positive, the same thing. This was, HER2 positive used to be a very aggressive disease, and now, thanks to understanding, research, and a bunch of patients who participate in studies, we've done a world of a difference. So options for chemotherapy are plentiful. A bunch of different types of chemotherapies. Many active and tolerable chemo choices. More is not necessarily better. No clear advantage to combination. Chemo, single agent chemotherapy is preferred, and the order of chemotherapy does not appear to influence survival. So when you do make a decision and you get to this point, be well informed, be involved. You may have several treatment options. Consider seeking a second opinion, learn about your options, what is standard of care, should I consider a clinical trial, and then make an informed decision that you feel comfortable with. One thing about triple negative breast cancer is the fact that we now know that there are many different types. So what you're seeing here is a graph of patients left to right. Each and every column is a patient, and top to bottom is a particular gene that seems to be differentially expressed in certain types of triple negatives. And so this type of research and data that comes from people donating their tissues and analyzing them has now led to a actually clinically available test by Insight Genetics called TNBC type. Now, key thing, do we have to all go running out there and figuring out what type of cancer do we have? No, not necessarily. Studies are ongoing to determine if such a classification should affect your treatment recommendations. And so it is available now, finally, sort of commercially. But I think we have to think twice about, okay, do I need it? Is it just like an academic issue? And sometimes there are clinical trials that specifically want you to do this before you enroll in a study. Because one thing about TNBC is, hey, especially when we have metastatic triple negative breast cancer, we want to know what the broken switches are. We don't want to leave any stones unturned. And normally we test for just estrogen and progesterone, and even patients who have estrogen receptor positive, maybe low, or HER2 positive, guess what? They can sometimes turn from positive to negative and end up with triple negative. It's not likely to convert from negative to positive, but when we do have metastatic disease and recurrence, it's worthwhile to rebiopsy. Next generation sequencing means analyzing not just 3 genes, but about 300 other genes to figure out, might your triple negative breast cancer be driven by some other gene that might look like a lung cancer or some other cancer that might be treated in a different way. Nowadays, circulating tumor DNA, a blood test, could identify molecular fingerprints of cancer with a blood test referred to as liquid biopsy. And this can be helpful in identifying that broken switch that we might be able to target or direct you to a clinical trial, or actually monitoring disease as well. And the very early studies in circulating tumor DNA. Circulating tumor cells also has its limitations, and then, of course, even if there is no suspicion of breast cancer, even on a patient who's 70 years old and doesn't have any a family history, we now strongly recommend germline testing because it can influence treatment options. So clinical trials are done to find new ways to treat cancer. We want and we need more effective treatments, new drugs, new combinations. All the treatments that we have now, it's because they were studied in the past. Recently approved treatments include CDK4/6 inhibitors for hormone receptor positive. HER2 positive has had a slew of approvals. And for triple negative breast cancer, non-specifically approved for triple negative breast cancer until technically yesterday. Tecentriq and Abraxane combo was FDA approved yesterday. And this is specifically for patients with metastatic triple negative breast cancer whose tumor tests positive for this protein called PD-L1, which I'll explain to you what it is. And that was roughly, according to the study, about 40% of all the triple negative breast cancer patients. It improved control of the disease by from 5 months to about 7.5 months, compared to chemotherapy by itself. And the chance of shrinking the tumor was about 53%. And most importantly, it improved overall survival. So it improved the patient's chances of living longer from about 15.5 months, which what that means is half of the patients died at around 15.5 months if they didn't get this new drug. But if they got the new drug with chemo, they lived for more than 2 years, 25 months. So this is a big deal. This is becoming now the best new standard of care for the first treatment patients with triple negative breast cancer. What is PD-L1? What is immunotherapy? Well, again, these cells started from within your own normal cells. Your immune system doesn't attack your own normal cells. Otherwise, we'd have, autoimmune diseases such as lupus and rheumatoid arthritis. When it comes to the way our body is created, on the left is a cell that the T cell, your immune system. Oh, we found it. Well, in case this was all right. So our immune system identifies the tumor cell, but then the tumor cell has this ID card that says, "Hey, I'm one of you. Leave me alone. Don't attack me." So when the PD-L1 and PD-1 engage, it's like an ID card of disguise that says, "Don't attack me." So there is no tumor cell death from the immune system. However, there are these couple of medications that have been incredibly successful for patients with lung cancer, kidney cancer, bladder cancer, melanoma, you name it, not on breast cancer until now. And actually, these medications work fantastic when you give it by themselves in patients with these other cancers. So there is a role now finally in patients with breast cancer and a lot of ongoing studies to try and make them a bit more effective than what they, or effective at all, because it doesn't work in everybody. And so what these medications do is they block it. And so now when you don't have that, now the immune system engages and it can kill the cancer cells. So one large clinical study that is looking for patients who are at high risk with a triple negative breast cancer, and if the tumor results positive actually this is in the metastatic setting. So what this means is if the tumor, for patients who have metastatic triple negative, if you test for this particular test we call MSI, not that many patients with triple negative, actually there's a decent chance that this immunotherapy will work well by itself. And in the study that got it approved, technically there were only 2 cases of triple negative breast cancer. So it's not very common. It certainly is worthwhile testing, the triple negative breast cancer when it is metastatic, test it for that. And then I'll make a point of, specifically this is for BRCA, for patients who are BRCA carriers. So what happens in our normal set, in patients who have are born with a genetic predisposition to breast cancer is, well, basically the strength of the cancer is its weakness. And by that I mean you're a BRCA carrier, uh, healthy cells, they have one defective BRCA gene, but they have one working BRCA gene, and that's good enough to keep these cells healthy, okay? And so that's a table at the top. And so what I'm trying to illustrate here is that our body has many different mechanisms to fix DNA damage when it happens. It's pretty small. We have a lot of backups. And there's a medication that we call a PARP DNA repair inhibitor that when we give it, we take out one of those mechanisms. And if you do that to a normal cell, to a healthy patient, it has minimal side effects. This table still stands. But if you're starting with a tumor cell, that the reason it started is because it lost that particular pathway to fix DNA, well, that tumor is already starting with a defect. And then when you give the same medication, when the cancer cell absorbs it, now you're blocking two ways of repairing it. And so now, you do have specific tumor cell killing. Why am I saying this? Well, because there are also these FDA-approved medications for now specifically BRCA mutated tumors, patients who have BRCA mutated tumors in the metastatic setting. And this can improve control of disease by additional 3 to 4 months compared to chemo and with less side effects. And there are long-term responders. A very rare but real option for patients with metastatic triple negative is this gene called TRK. And basically this is truly leaving no stones unturned. If you have metastatic triple negative, if you test for this, it might be rare, but if we do find it, then this medication can work and work well. This is a gene, it's a driving gene for many other kinds of cancers, and it is approved for any tumor that tests positive for this. So keep in mind, we don't know it all, and clinical trials are trying to answer the questions, what can we do better? And clinical trials for specifically triple negative breast cancer are ongoing. At least 159 clinical trials as of yesterday when I kind of was looking. And they're looking for immunotherapy, vaccines, androgen blockers, I'll talk in a bit. And a good website to kind of reach out to is breastcancertrials.org. And there's some wonderful organizations downstairs in the sponsor, in the exhibitor sections that you should look into. Some clinical trials, for example, are asking the question, well, can we prevent the breast cancer from coming back in the first place? This study, a national study, is looking for patients with, these two studies are looking for patients with triple negative breast cancer at high risk for recurrence, and we're giving immunotherapy to try and see if we can make a difference. And these are studies where patients are randomly assigned to best standard of care option right now, which is neither of these treatments, versus the drug that they're studying. So for example, Keytruda. So even though you're not guaranteed you're going to get medication, or you're at least going to guarantee that you're going to get the best available treatment option available today. And then, of course, there's this other study. Well, sometimes the issue is not about, turning on the immune system, but stimulating it with a particular antigen, if you will. Much like we prevent infections. So global H is a protein that's expressed in about 60% of patients. And this vaccine was studied and it improved control of disease in the metastatic setting. And now the question is, can it prevent cancer from coming back? And here we see that the vaccine we give, which is this brown and yellow stuff, stimulates the immune system. It then turns on your immune system to create antibodies against this protein that is also in the tumor cells, and then it basically triggers a response. And again, we're hopefully killing off whatever little teeny tiny cell may have been left behind after our best standard of care treatment option. There's a study called Gloria, which is enrolling nationwide. and worldwide. Another emerging therapy is a medication that we call sacituzumab. This is like a Trojan horse. Basically, you have an antibody that identifies the cancer cell, and then on that antibody, we're hiding some really potent chemo. And so when the antibody gets to the cancer cell, it doesn't do anything to it, but then when the cancer brings it inside, it explodes and the chemo is released into the cancer. And that's how we can better deliver chemotherapy. This strategy is specific to patients who have this particular gene, protein expression TROP2. A recent study, 2018, it was a 100-patient study, small study, single arm. It was given by itself. It wasn't randomized, and yet 34% of the patients the tumors responded, and it lasted about 9 months. The results were better in patients who had the particular protein, and there were not 9 long-term responders. There is another a larger, as I said, sometimes small studies, we want to validate them. We are awaiting a larger study, completion enrollment for this study called the Ascend clinical trial, which is available now too. And there were a little bit of a hiccups in getting this medication approved, I think in regards to manufacturing, but we're hoping that it'll be available for us soon. Emerging therapies, right? Other switches that can be on. There's this pathway. Sometimes we're like electrical engineers. Well, we're trying to figure out the cables that which wires we got to cut to prevent the cancer from growing. And this is one of those cables. PI3 kinase AKT pathway. It's often activated in triple negative, and a small study showed that when you add this particular compound to block that pathway, when we add it to chemo, we get better responses. So a larger validation study is currently being conducted. And these are just a couple of as I mentioned, 159 studies that, some may be close to home, some may not be, but, it's important to know that, and these things constantly change. Another emerging therapy is testosterone blockers. I'm putting here visualizations of a response to giving an androgen blocker. So it is very well known that some triple negatives, not terribly common, but some triple negatives are actually driven by the testosterone receptor. And we can do that protein test. I do strongly recommend that protein test be done in patients with metastatic triple negative, because if you do find it, there are many trials that are ongoing looking for patients so we can get the drug approved and use it for other patients. So here, this is somebody after 3 months of that testosterone blocker or medication, a pill, the tumor has significant shrinkage. So it's that big white thing that responded to this testosterone blocker. And now, unfortunately, testosterone blockers can also have significant side effects. So it's not a perfect drug, but it's effective. It can be effective. Another one is, you've heard of HER2. Well, there's also HER1. And HER1 is a factor that can be the driving mutation of a triple negative breast cancer. Currently, they're only approved for lung cancer. And here I report a case report of a woman who had metastatic unresectable triple negative breast cancer to the skin, and she's been on this lung cancer medication for 5 years after she achieved a complete response and currently has no evidence of disease. And maybe in between those 5 years had a recurrence of the triple negative in the other side of the axilla, was resected, but at the end of the day, she continues to benefit from this treatment. I would, if you have metastatic breast cancer, Metastatic Breast Cancer Project allows us to learn more in a different way. You don't have to go to a particular institution, and that's the only way we learn about what happens, but rather, this reaches out to anybody anywhere around the United States, and, it's fairly easy to kind of consent, and at the end of the day, what they want is sample of the tissue and the clinical information, and we can learn a lot from that. So a patient that I just described goes in there, well, how many more patients had that experience? Now, just to get you a little bit excited here, although, kind of challenging, but another potential strategy that is currently being looked at is imagine taking your immune cells, like a blood donation, but we focus on the white blood cells, and then we genetically manipulate these white blood cells and train them to identify the cancer. Ooh, I might need the other computer. Yeah, to finish it, I got like 2 or 3 more slides. So in the meantime, so imagine we can train your immune cells to identify the cancer as bad. We multiply them outside in the lab, and then we give them back to you in the vein. So that treatment is actually currently approved for patients with refractory leukemia, and it works incredibly well. It's incredibly expensive too. And right now there are studies for HER2-positive breast cancer, and the University of Washington it just did the first in-human study for triple-negative breast cancer, looking specifically at a particular protein, right? You have to have the target. You have to have that protein that the white blood cells can identify in order for it to work. I was almost done. I think I have a presentation here real quick. I'm sorry about this. I'm improvising. But anyways, maybe we can pause and ask some questions, and I think I have 2 or 3 more slides. Okay. 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 So good question. Good question. When it comes to early stage triple negative breast cancer, we do not routinely recommend that all of this exhaustive workup information about what does my triple negative breast cancer look like. We're not doing them right now. Now, one could make the argument that maybe, and we're kind of very small early discussions of potentially doing a study where doing, for example, this circulating tumor DNA test, right, where it actually identifies molecular fingerprints can identify molecular fingerprints, evidence of cancer in your body after you've completed curative intent treatment. Right, so we identify that can be kind of scary, like that shouldn't be there, molecular evidence. Well, this is exactly how we treat patients with leukemia for the last 30 years. They present, they're very sick, we see that under the microscope, there's a lot of cancer cells, we treat them with chemo, and then they go in remission because now all the blood counts look normal. But then we do the circulating tumor DNA test, and we see that, nope, there's molecular evidence, the disease is still there. And then those are the patients that we know for a fact, we've already proven, if they go to a bone marrow transplant, which is a way more intensive treatment, they have a chance of cure. They have another chance of cure. We're not there yet. We're not there yet with solid tumors in general. We're not there yet with triple negative breast cancer, but I think that's what the future holds, where if we do this particular test and we find molecular evidence, there's 2 parts to the story. There's, is my cancer going to come back, and when? But then there's, what can I do about it? And I think those are the 2 things that we need to reconcile before we do an exhaustive workup and find out that I've been treated for triple negative breast cancer. I found out that it's androgen receptor positive. Should I be in an androgen receptor blocker right now? The answer is absolutely not. I mean, for all we know, the androgen receptor positive have a much higher chance of cure, and it's never going to come back anyways. And all you do is suffer the side effects. So, the short answer to your question is we do wait for metastasis to happen. I do strongly encourage that all these tests are done to get a bigger profile of what type of disease we're dealing with and what our options might be. That's okay. Any other questions? Somebody had one here up front.
So you mentioned the trial and the website for the, you can go on there to look for the trial. What kind of help us, I guess, make the decision. So if you finish treatment, but
Uh-huh.
you did not have a pathological
I see.
response, whatever it's called,
Sure.
how do you determine whether or not you should do the trial? I mean,
Sure.
psychologists, and what if they're just like, well, yeah, trials are great, but I don't know.
Sure. So a good question. I do think we need to be a bit proactive about this. And the website that I said, for the clinical trials, and then some of the trials can be a little bit challenging to navigate. A lot of them have reach out numbers, a phone number, and a lot of them have research coordinators waiting for a phone call from you, so that they can learn a little bit about, okay, tell me your situation, and kind of do a little teeny tiny free consult just to screen and figure out, might you be a candidate for the study. So feel free to pick up the phone and call your either nearest academic center, or feel free to reach out for second opinions. And if you feel like you're not getting that sort of path, in front of you, because it depends where you live, of course, right? Of how much access you have. I think, me practicing in Austin, Austin, San Antonio, Dallas, Houston, I think if you find the challenge of the travel, sure, that's a factor, yes, but that shouldn't just be the factor to at least pick up the phone. Let me see, is it an option? Is it worthwhile? Some studies will pay for your travel, will pay for your, commute. And so, the short answer is, pick up the phone and call. And second opinion, not necessarily something that's negative against your, current treating doctor. It's just, what are your thoughts? It's like getting information from another professor.
Those of us who haven't had a recurrence, is there any new information, if you're HER2 or positive, there are some treatments you can give to reduce recurrence. Anything new on that front for those of us who are in between?
Sure. Well, so I think so specifically for, patients who do have a pathological complete response, it can be really hard to further figure out who continues to be at risk in the future. Short of, the potential of these circulating tumor DNA tests. But right now, sort of the best, and it's not even a perfect test, this pathological complete response. As you see, this, just because we didn't have it doesn't mean that it's automatically going to come back. It just puts us in an uncomfortable risk. But when we do have the pathological complete response, at the end of the day, if we were to do a trial with patients who ended up in that situation and they're randomized to an intervention or not, we might need 2,000 patients to detect the difference, if any, and it can, that's the challenge. So this is, so that study I was telling you about is about a protein called ROR1. Yeah. Oh, it's not. Ooh, okay. It's. That's weird. Go ahead. Yes.
Yes, I would like to know for triple negative patients, why the research have taken so long? Because it's a small percentage of 15%, and yet the women that's getting triple negative now are under the age of 40, in their 20s and 30s, and have ran into some that's even 19. Why no research, and billions of dollars is going into these companies every year for research, but no one have really invested in triple negative patients. And now you get young mothers, young single mothers, 20 and 30 years old, who can't even have children. And then I would like to know, what about when they start chemo? Why no one is addressing them harvesting their eggs? Because when they start having chemo, they become infertile, that they don't even tell them that. And then they don't even have companies, but one company that pay for the pharmaceutical. Because even with my daughter, with the help of her harvesting her eggs, I still had to come out of pocket for $2,500. So why triple negative people are not,
Sure.
And all I hear is research. We walking. Well, what
Yeah.
are we walking for?
Yeah. I would say so a couple of things. I think you're absolutely right on the fertility issue. 100% of young patients should be referred to a fertility specialist to at least learn about their options. There absolutely is, unfortunately, a financial challenge when it comes to that, and there are some organizations, that help support that, and I've seen it in my experience where some of those organizations and funds go up and down and up and down, and some patients have it available, then all of a sudden they don't. Um, but it's absolutely essential, and I think we do rely on our fertility specialists to help us gather what are the resources that our patients can have to get to that point, to be able to harvest eggs. I think to the point of research specifically in triple negative breast cancer. Well, I think if we were to go back, let's say 30 years, one could make the argument HER2 positive breast cancer was triple negative. We didn't know what HER2 was, and there were a lot of, call it, patients that were hormone receptor negative. We didn't know what HER2 was, but the hormone receptor negative was the population that's here right now, right? We didn't have another option. And so what we are really doing, and listen, having worked with, investigators behind the scenes that they're in their labs right now, and they're, dedicating their lives to writing grants and getting a chunk of that billions of dollars, so that at the end of the day, they're trying to figure out if their research is going to lead to the next cure. There are people that are working hard behind the scenes to get what we need, and it's happening, and that's, I think, how we ultimately figure out, well, wait a minute, HER2 positive is a different disease that can be targeted. So now we take that away, and then we say, and so it becomes a different kind of cancer. And the studies are ongoing. A lot of it of what I've mentioned today, the androgen receptor positive, I have to admit with you, it's pretty disappointing on, I would say, the results, right? I kid you not, there's probably about 100 approvals, indications for immunotherapy for other cancers. But not until yesterday was it breast cancer. And I can promise you, it wasn't because of a lack of trying. It just so happens that for immunotherapy, it works great for other cancers, and it hadn't worked great for breast cancer until now. So I think it's fantastic news that we got yesterday. And what is also making it challenging is that there's a lot of different subsets of triple negative, right? And so if you do a study of many different kinds of cancers, then you might actually find that it might work for 5% of them, but the other 95 muddies the water, and you don't get to see that response. So I hear you. I hear you, and I think that we can always do better. And I think
We can, but we also need to have early mammogram for women that's under 40, because the standards say that insurance companies do not pay for a mammogram unless you are over 40 over 40, unless the doctor see a reason fit or in the family to take a mammogram. And so you have a lot of women that's underneath of 40 that can't even take a mammogram because insurance companies don't pay for it. So then by the time they be diagnosed, they in later stage.
Yeah.
So if they took the mammogram earlier and had the 3D imaging, then maybe a lot of cancer would be caught.
Sure.
The younger generation that's underneath the 40 years.
Sure. We do have a big challenge in detecting triple negative breast cancer earlier. And one last point, this is how we get to the end, at the end of the day, preventing women and men from dying of triple negative breast cancer. And we can't do it by ourselves. We have to do it together. And the left part of this slide is you guys. The left part of you guys is there's survivors, there's advocacy, right? Unfortunately, many of our loved ones and friends have died of triple negative breast cancer, and they can't speak for themselves. So we are their survivors, and we have the ones that have to stand up and raise awareness about all this, because that way we will detect them, they will happen, we will diagnose them, we will treat them, and we will create more survivors. Okay. And I think, Young Survivors Coalition does this.
Okay,